You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for May 4th, 2018. This week, stroke guidelines, pulmonary embolism care, Mitra-clip, eating nuts, and a discovery in blood pressure measurements. The first topic today is guidelines. The lead story centers, in fact, on the fragility of guidelines. But before I tell you about that, let me go over some brief pro and con statements about guideline documents. First, the good news. I always recommend to new APRNs or PAs that join our practice, we rarely hire doctors anymore, that they read the AF treatment guidelines. These are good documents. The reason I like guideline documents is that most of them do a good job with evidence review, and they get new clinicians really close to the right care. But there's downsides, though. The first is that guideline documents can be conflicted because the writers have relationships with industry, and this can lead to overly rosy views of dubious treatments. Two examples, dronedarone for atrial fib and TPA for stroke. Second downside of guidelines is that although these documents are meant to be guideposts, they can morph into law, especially when payers decide to pay only for things that make the document, or worse, when guidelines become quality measures. This is especially terrible because not all patients fit the guidelines, and in some cases, take the elderly, the guideline recommendations can push doctors to use therapies that have only been studied in younger patients. In fact, this is one of the major criticisms of the new hypertension guidelines, specifically that they didn't really make distinctions about age. Now finally, the third downside, and I know this because some doctors have told me, is that some doctors use guidelines to the letter of the law. In other words, if it's in the guidelines, they use the treatment. One example is LifeVest. One doctor told me that until they take it out of the guidelines, he will continue to use it no matter what the studies show. So with that as a background, this week the AHA and ASA rescinded large parts of its recently released stroke treatment guideline document. They published a correction in which large parts of the guidelines have been deleted. Now the AHA says this is temporary as they are preparing modifications to the parts that have been deleted. But get this, the rescinding of the major areas of the document was done without the agreement of the writing committee, or at least the majority of the writing group. This is very controversial. Journalist Sue Hughes has an excellent recap, and I learned from her story that the guidelines appeared to question many of the things done in routine treatment of stroke, and this resulted in perhaps, quote, too narrow a perspective. Now, why did this happen? Well, because the guideline writers used evidence. Sue Hughes used the example of dysphagia screening. One expert said it was crazy not to screen for dysphagia because screening for dysphagia makes sense. Well, an independent committee reviewed the evidence for dysphagia screening and found very little support for the practice. So the guideline writers said they did not think there was enough evidence to recommend every patient must have this. Instead, they said it is reasonable but not mandatory. Well, that creates a problem because things that are not mandatory or necessary might not get paid for. It's hard for me to comment on the details of each of these sections. We have to see what comes of the rewrite, but I do worry about the idea, the general concept of the AHA and ASA unilateral decision to rescind evidence-based recommendations that question routine practice. Well, why do I worry about it? Well, you don't have to be in practice as long as I have to realize that, quote, routine practice can sometimes be quite wrong, especially when it is based on expert opinion and just common sense. Second topic, pulmonary embolism. This is a deadly condition that often goes underdiagnosed, and that's why any new breakthrough deserves our attention. But first, full disclosure, the lead author of this new study is my partner and friend, Dr. Thomas Tu. He presented at the SCAI meeting a study called the FLARE study, and it looked at upfront catheter-directed mechanical thrombectomy without the use of any lytic therapy. This was a single-arm study done at 18 sites with more than 100 patients who had new onset PE symptoms and an RV to LV ratio of at least 0.9. The main finding of the study was that RV-LV ratios significantly dropped after the clot was mechanically removed with this proprietary retriever called FlowTriever. The absolute reduction in RV to LV ratio was 0.39, and that compares favorably to previous trials with lytics. They had 4 patients have a major adverse event, but importantly, all but 2 of the patients in the study did not receive lytic therapy. And Dr. Tu noted that patients often feel better instantaneously on the table once the clot is extracted. Journalist Patrice Wendling gets comments from 2 outside experts who appropriately express both excitement about a new treatment and caution that this is a modest, non-controlled proof of concept study. As a first-person observer of this, I can say the visual images of these extracted clots are quite impressive. But more important than just pulling clots out is what has happened at our hospital. It is a greatly enhanced PE recognition and intervention approach. And given the morbidity and mortality from PE is so high, and that the median age of patients in this study was only 55, this seems like a hugely positive development. Third topic, Mitra-clip. The Mitra-clip was approved in 2013 for treatment of patients with significant symptomatic degenerative mitral regurgitation who were too sick for surgery. In the U.S., the Mitra-clip is not approved for the much more commonly encountered problem of functional MR. However, in Europe, functional MR is one of the most common reasons for Mitra-clip use. So this most recent study, called the Post-Approval Study 1, PAS-1 study, is the first and largest report of echo and clinical outcomes through 1 year. These were older patients, mean age 80. They had a good implant rate of 97%. At the time of the procedure, 86% of the patients had New York Heart Association functional class 3 or 4 heart failure, and 77% had severe MR grade 4+. So these were sick patients. And the study findings essentially are that the degree of mitral regurgitation got significantly better, ventricular volume declined. They also noted improvements in 6-minute walk test and quality of life scores. Now, they did have 1 in 5 patients die in this first year, and that 22% mortality is quite high, but these are older patients with significant heart failure. There's not a control group or even a propensity match group, so it's hard to say much about the mortality rate. Also important to note is that in an unblinded trial, it's hard to say much about improvement in 6-minute walk test and quality of life scores and subjective symptoms. My take on the Mitra-clip device is that it's interesting and promising, but we need more robust data than just non-controlled registry studies like this. I do worry a little bit about the percutaneous and surgical approaches to valvular heart disease being potential areas of overtreatment. Next topic is nut consumption. Now, here we go again with nutritional association studies. The latest one found that eating nuts several times per week may play a role in reducing the risk of AFib and possibly heart failure. Publishing in the British journal Heart, authors from Sweden performed this large prospective study and found nut consumption associated with an 18% reduction for AFib. Now, they also found inverse associations between nut consumption and the risk of MI, heart failure, aneurysm, and these were attenuated with risk adjustments. These findings are in line with previous meta-analysis that looked at CV outcomes, but there's sparse data on nut consumption and atrial fibrillation. So here was the key phrase from the paper, quote, people who ate nuts tended to be better educated and have healthier lifestyles than those who didn't eat nuts. They were also less likely to smoke or have a history of high blood pressure. They were leaner, more physically active, ate more fruits and vegetables. My friends, this is called confounding. And even though researchers try to control for it, it's still there. It's there in nut studies, chocolate studies, blueberry studies, all of these sorts of studies. I like nuts as much as anybody else, and I think patients are probably far better off eating nuts than potato chips or Cheetos, but I would not get too excited about nuts as an antiarrhythmic agent. Final topic today is a very interesting study about blood pressure measurements. Now, hypertension is obviously a major CV risk factor, and therefore blood pressure measurement is critical. But the type of blood pressure measurement, these cuff measurements, have not changed in more than 100 years. So a group from Australia has shown previously in a systematic review and meta-analysis that was published in JACC that cuff blood pressure has variable accuracy and could be inaccurate in the gray zone when blood pressure is in the range of prehypertension or mild hypertension. And I say inaccurate in that the cuff blood pressure may not accurately reflect the intra-arterial pressure in the brachial artery or aortic pressure. So this same Australian group has now published a new study that found evidence of 4 different phenotypes of blood pressure transmission or amplification. So first of all, we need to sort out that there is such a thing as blood pressure amplification. Typically, blood pressure is lower in the aorta and is higher farther down the arterial tree in the brachial and radial artery. So in this study, the authors elegantly measured 2 blood pressures. First, they measured an invasive aortic blood pressure during a heart cath, where they had a catheter in the aorta, and then they compared it against blood pressure in the periphery with multiple different cuff measures, like automatic and oscillatory methods. And they found 4 phenotypes, 4 different groups of patients. First group had normal amplification from aorta to brachial to radial. In the second group, they had normal amplification from the aorta to the brachial, but then no amplification out to the radial. Third group had no amplification from aorta to brachial, but then did amplify from brachial to radial. And then the fourth phenotype, the fourth group, no amplification of any blood vessel. These 4 groups led to 2 take-home messages from the study. And one was that in the latter 2 groups, the ones that had no amplification from the aorta to the brachial artery, had consistently higher systolic blood pressures in the aorta. Second take-home was that no cuff could accurately identify these phenotypes. So just let me give you a brief example. In the first phenotype, the radial blood pressure could be 150 systolic, but the aortic blood pressure would be 122. Whereas in the fourth phenotype, the radial blood pressure could be 150, but the aortic blood pressure is also 150. So like a 30 millimeter difference in central blood pressure. This is a provocative discovery. The authors speculate that the latter 2 phenotypes, the ones with no amplification, would have higher cardiovascular risk. It's just speculation. And these findings do not undermine the importance of taking a cuff blood pressure, but it suggests that improvements in cuff accuracy could lead to even better performance of blood pressure as a risk management tool. And what did they conclude? They call for more research into how to non-invasively determine individual phenotypic patterns. Really good conclusion. Take a look at this paper. It's published in the journal Hypertension. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. This is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.